Hi guys, we are recording today mock 14, the paper which was there in September 2022 exam. The previously till mock 7, till SBQ 7 we have already recorded, and today we'll be recording the explanations. Though I've provided the feedback, but you always know when I start explaining, I go into various topics for a detailed explanation, which is like very informative and helps you to understand more better. So yeah, let's start. This is for ADC Part 1 exam, and I'm sure if you're watching this video, you must have watched others as well. So hope this is helpful to you also. Uh, Now this topic of anaphylaxis is very, very important from the clinical perspective, from Part 1 perspective, from Part 2 perspective. So what I've done is I have got a very nice PPT about it here, which I've downloaded and I've uploaded it in the charts and guidelines folder for all my enrolled candidates so they can have a look. It's a short PPT of just 23 slides, a very nice PPT. So I would suggest go through this for a better knowledge of anaphylaxis so as to brush up your basic knowledge. But otherwise, I'm pretty sure you have read about it, you have heard about it, and hopefully in your lifetime, I hope, really hope and pray that you never get to see one because it's one of those medical emergencies which is going to give you nightmares, and the patient's life is at risk, and everything happens so fast. And though we have read about it, I don't think so anyone of has ever trained practically in a live patient who's undergoing anaphylaxis to actually do something about it apart from just calling the ambulance, because the respiration itself becomes a problem, and you all know that 5 minutes without oxygen you're dead. So 5 minutes just pass by so quickly, and you will panic if you see a patient. The patient will panic, and it's a disaster. So hopefully to God, never anyone of you all see or I see a patient like that ever, and I hope nobody ever suffers with that. But in case you do, because there's always a first time, because even the patient might not be aware, you should be prepared for it. So you should know what needs to be done, and hence it becomes a medical emergency question, a very important question, as life is at stake. So go through that PPT, all of y'all, in charts and guidelines folder. Now, always at any point of time, if any question has to be asked about anaphylaxis, it is pretty much the same. Just the scenario would be different, but pretty much the question would be mentioning that a patient, now in this scenario, it's a 17-year-old female, it can be anybody, becomes unwell, develops shortness of breath, and a facial rash. Now, shortness of breath and facial rash immediately after you do something is a classical sign of anaphylaxis type 1 or hypersensitivity type A in your dental reception while eating a snack. Okay, so the patient is at the reception. It can be on a chair as well. Example, you have just given any medicine or something, or the patient has taken something or ate something, and now the patient feels unwell, hot, and breathless. Breathless is a key word, okay? Her face is itchy. Itchiness is another keyword. Has asthma, which is well controlled. Asthma is controlled, but right now she is having short breath. Okay. She also suffers from eczema, that is, she already has allergy of some sort going on all over the skin. Apart from that, she doesn't have any drug allergy. So, probably the snack that she is eating has triggered this kind of infection. Maybe she wasn't aware of it, and now she's got it. Now, because she has shortness of breath and a facial rash, and now she's feeling breathless, immediately you should point out to anaphylaxis. So let's see what the options are with us. It's herpes zoster. Well, shortness of breath won't be there. Lichenoid reaction. Lichenoid reaction happens where some substance is in touch. Example, amalgam is there in the cheek, will develop a whitish rash, but definitely shortness of breath won't be there. Latex allergy. So an allergy can cause shortness of breath, but then again, the term for that would be again anaphylaxis. So here, the patient may have allergy to something, but we don't know what it is. And since she's at the reception, Nobody has touched her with latex, so you cannot just point out to that. Allergy to salbutamol. Well, salbutamol is used in asthma to cure allergy. It doesn't cause allergy. Understood? So here, but obvious, it's a very simple giveaway question and answer. It's anaphylaxis. Now let's come to this PPT to understand what can trigger anaphylaxis reactions. Now see, when the question is mentioning the patient has eczema, that means some sort of skin allergy is there. So your ears should just, light up those antennas. If the patient has one type of allergy, the patient might end up with other sorts of allergies. So always make a point to ask two, three more questions to the patient, that what happens when the allergy happens. Is there any particular food that also causes? Is there any medicine allergy? Like prod the patient a little bit. The patient might say, yeah, yeah, I had something. So then you should ask what had happened. Well, I had got rashes. All right, was that it? Did you ever develop shortness of breath? The patient might say no. Fair enough. So at least you have a background that some sort of allergy is there in patient's body, but so far they never had shortness of breath. If at all they say yes, at one point of time I was really short of breath and something was done, immediately you should become very, very careful and ask them, then do you carry an EpiPen? Because most of the time, if a patient had an anaphylactic reaction before, they would be carrying an EpiPen with them. So in case the patient says, yes, yes, I do carry an EpiPen with me every time where I go anywhere, then you ask them to show you that EpiPen. You check it. You keep that EpiPen in the reach and you ask the patient, do you know how to take it? Mostly the patient would know how to take it, or the person accompanying the patient might know how to give it to them. So, in case you have never used the EpiPen before, but the patient knows how to use, learn from the patient right there and there. Like how they stab the pen, or Google it right there and there before starting any procedure. Because what if you need it during the procedure? Just seeing the EpiPen won't make you confident or competent enough to use it, right? It's okay. Like you have never used it before, fair enough. But there is, you should not be like appearing illiterate about it. You can always Google, there are many YouTube videos how to use it, and just jot down on the patient and be very, very careful with the patient. At any least sign of development of shortness of breath, you should be very well in the controlled situation and not panicking yourself. Okay. So, this is how you approach a patient who either had an episode or never had an episode but is allergic to some stuff. So let's go. What usually triggers anaphylaxis? Usually it's peanuts, nuts, fish, shellfish, and milk. Well, peanuts and nuts are normally not allergic to a lot of Asian kids. I mean, they are, but it's the frequency is very less. A lot of Europeans and Americans, all these people, many of them you'll find the parents will be saying, yeah, my child is allergic to nuts. So you'll ask what happens. Oh, a rash develops or a little bit swelling comes, but there has never been a shortness of breath. All right. So keep that in mind. Now, certain medications, including antibiotics such as penicillin and its related drugs. Penicillin means amoxicillin, aspirin, and IV contrast used in some imaging tests. That's why, sometimes when you go for certain major invasive things, they do an antibiotic test dose on your arm and they see if you are allergic or not, because they don't want you to end up with this kind of thing. So of course not everybody will develop allergy, but there are certain people who do, so that's why they do the test reactions, which we never do even for local anesthesia or something, though ideally we are supposed to do it. But since the incidence of the allergy is so less, that we tend to just directly proceed with the treatment. Stings from bees and other insects, latex, exercise. Latex allergy, a lot of people have, a lot of dentists also have, including me. Whenever I wear powdered gloves, the latex ones, my skin gets rashes, like small boils start to come up. So I have to go with the nitrile gloves. So latex allergy, a lot of people have. Now, some people will have it to a greater extent that they might develop anaphylaxis. Others them might just have a lot of dermatitis. So delayed hypersensitivity reaction, which can be very well controlled by either avoiding that substance or applying some medicine. But latex can also cause severe reactions like anaphylaxis. So, all these things. Understood? Now, the pathophysiology of the anaphylactic reaction, you all know that there is an IgE cell which binds to the mast cell, and subsequent exposure to the same, it just triggers the mast cell to release histamine. Now, anaphylaxis, so what the allergen does basically, the allergen is a very small amount that comes in contact with you, but it causes simultaneous bursting of the mast cell, which releases histamine. Now, it's the histamine which causes all the problems. Understood? That histamine is produced in our own body, but simultaneously, it's like a bomb blast happening inside the body. Now, this histamine is the one which will cause bronchospasm and vasoconstriction, vasodilatation, I'm sorry. So, it will narrow the airway and it will dilate the blood vessels. So, when the blood vessels are dilated, a lot of fluid gets accumulated in the periphery. You understand? Which the heart is not able to pump up nicely because it's not receiving enough blood supply, as all the blood supply has started pooling up in the peripheries. So there is not much fluid in the system, and that's why hypotension starts happening. And because there is bronchospasm, you're not able to breathe properly. Now, the natural antidote of histamine is adrenaline or epinephrine. Now, when you give adrenaline, it has a reverse effect. It dilates the bronchial area. It's a bronchodilator, the best one, and it causes vasoconstriction. So it starts sending the blood back to the heart. You understand? That's why we give adrenaline. So whatever reaction happens in anaphylaxis is purely because of the release of histamine. Like a large amount of release of histamine all over the body simultaneously. So the body kind of goes out of control. So you have to diagnose anaphylaxis really fast in case it happens, because time is of essence. As if the patient can't breathe, then the brain starts to get deprived of oxygen, and I think 90 seconds or 120 seconds is the time the brain can be without oxygen. Otherwise, it starts really to go into irreversible kind of damages. So you have to identify the symptoms very fast. So the first sign would be itchiness, then there would be shortness of breath, and then other things will start, which are mentioned everything here. You can always go through this PPT, which, like I've mentioned, have uploaded in charts and guidelines folder. And then once you have identified this as anaphylaxis, of course, you'll call the ambulance, but now you will start managing the patient on the chair itself. You won't wait for the ambulance to arrive. The first thing that you should be doing is to open up the bronchus. The patient has to breathe. So you would take 1 is to 1000 adrenaline in a dose of zero point 0.3 to zero point 0.5 milligrams or 300 micrograms. So if it's not milligram and the answer says 300 microgram, that is also correct. And you would inject intramuscularly. Always remember that. The only way in anaphylaxis that you're going to administer epinephrine is intramuscular, not intravenous. See, intravenous is not possible also, because since vasodilation has happened and there would be so much of swelling all around the body, it would be really difficult to find a vein. Okay. So intramuscularly is the best option here, and then you have to repeat it 5 minutes as needed, and I think you can repeat it max 3 times. So that is the first thing that you will do, and after that you will give an antihistaminic. You can give a salbutamol inhaler, and you can also give a corticosteroid, but that all comes later. The first and the foremost thing is epinephrine, and after that oxygen inhalation, all these things. So this is the ideal management. Start with this, and then make the patient comfortable. So you will abandon, of course, all the procedures. You will not continue any dental procedure. Now, there are more details about anaphylaxis and how it is manifested orally with pictures and diagrams and everything. the important stuff basically along with the doses, please go through the charts. We'll go back to our question. So now we have identified that this, what is the likely diagnosis is anaphylaxis. Now, signs and symptoms of immediate onset allergic reaction. Now, immediate onset allergic reaction is anaphylaxis, includes all of the following except. So, the other name of anaphylaxis is immediate onset allergic reaction. So, you see how they nicely give synonyms to confuse you? Include all of the following except. Now, what did I tell you? The patient will always go in hypotension because a lot of fluid is getting pooled in the extremities. So it cannot be hypertension. Swelling of the lips is present, rashes are present, cyanosis is lack of oxygen, so bluishness of the lips, small airway obstruction, correct. But there will never be hypertension. It will always be hypotension. Anaphylactic reaction can be controlled without adrenaline in case of. So what the question is saying is that suppose there is a mild anaphylactic reaction. Mild means there's itchiness, redness, but shortness of breath is not there, probably. So if there is no shortness of breath, then you don't have to give adrenaline because the main function of adrenaline is to create bronchodilation so that the patient can at least breathe, you know. But if the patient is able to breathe properly but just develops rashes or itchiness or mild swelling, but there is no shortness of breath, then you start with antihistaminic, salbutamol inhaler, or some corticosteroids. You don't give adrenaline unnecessarily. So the question is basically asking, uh, in an anaphylactic reaction, suppose there is one and there is no shortness of breath. So in what scenario would you not give adrenaline? So this is it. When there is rash and mild swelling only, you will not give adrenaline. Otherwise, if there is bronchospasm, you will give. If there is hypotension, you will give. Hypotension means severe swelling would be there. If there is edema around the airways, again bronchospasm only. So bronchospasm as in because there is so much edema around the airway that there's so much pressure on the airway that even though from within it's not constricted, but the outside pressure is causing it to collapse. And you want to relieve that. So adrenaline would be given in that scenario. But just in a case of rash and mild swelling, you would not give adrenaline. So this is what the question means. What is the first line of treatment would you perform for this patient? Now look at the options here. We do know 0.5 ml of 1000 is the correct dosage, but here they have mentioned IV. Had they just mentioned here IM, I would have 100% opted for this option. But since they have mentioned IV and I told you IV is not possible, I cannot choose this option. So don't rush in to mark, read through the other options as well, even though you feel the first option may be right. That's how you will not ever fall in the trap of ADC. Second option is give adrenaline 300 micrograms IM via auto-injectors and salbutamol. Fair enough. Seems like a correct answer. Give chlorpheniramine 10 milligram IV and hydrocortisone. This is also correct. But is that my first line of treatment? No. Because it's asking what you perform for this patient and this patient is having shortness of breath. B and C only. A or B plus C. So either this, all the options are correct except this one, okay? Because it mentions IV, but then it says or also. But since they have mentioned IV, I cannot choose that option. And because they have mentioned first line, I cannot choose the option C. So if I cannot choose option C, automatically D and E options are out of my scope. So the only option that stays right is option B. Hence, that should be my answer. Another patient, now we are talking about another patient came with her mother after 3 or 5 days, and her mother stated that she developed urticaria after last visit. What will you do or tell the mother? Well, since the mother stated that she developed urticaria after the last visit, you should think what could have happened. So, is it because of your treatment or is it something that you did outside? Either way, she's developed an allergy. So, if she has an allergy, then you should refer the patient to an allergy specialist and find out what is causing the allergy because What if the latex glove has caused her and that was her first exposure? Now, if you're going to use it again, maybe she'll have a fully blown allergic reaction like anaphylaxis, and you wouldn't want that. Or maybe it's not your latex glove and it's something else which the patient is not aware of, but irrespective, she's developed urticaria. So, might as well let the allergic specialist, do the investigations and find what the cause is about. So, the answer should be C. I hope the anaphylaxis part is clear, guys. Correct? So I hope this presentation helped you all, and leave a comment as to how you liked it. Thank you.